Welcome back to the WHY-O-MYO Podcast. This is Janine Stiene, your host, hoping to answer your who, what, when, where, how, and why questions when it comes to myofunctional therapy. Is it common for the medical and dental providers to disagree with a myofunctional therapist's assessment of the lingual frenulum? And the answer to that is absolutely. Each one of us or each specialty is looking at the lingual frenulum in a different way. So from the perspective of an ENT or even the pediatrician, they are not going to intervene or recommend a frenectomy or a lingual frenectomy if the patient is not having any issues with chewing or swallowing or latching or colic. So if there's no reason to provide a frenectomy, then they won't do one, or they won't recommend one. A dentist, on the other hand, assesses the frenulum with regards to being or falling within functional limits as the person's ability to stick out their tongue and touch the very bottom of the pink on their lower lip. So if a patient is able to do that, a dental professional may say that they have enough range of motion. But as a speech pathologist, we are looking at the frenulum with a different perspective. We need for the patient to not only be able to elevate and depress their tongue to the bottom of the pink of their lips, but we need them to be able to mobilize the tongue independent of the rest of the oral structures. In addition to that, we need that movement or that dissociation to include just lingual movement, not jaw, not shoulders, nothing else moving except the tongue. The other thing that we need for our patient to be able to click their tongue. And when they're clicking their tongue, we need to see that the blade or the middle of their tongue is able to make contact with the top of their mouth or their hard palate. If the patient is unable to make contact with the tongue blade and the hard palate, or the middle of the tongue and the hard palate, or the tongue tip to up a little behind your front teeth, or stick out your tongue as far as you can and depress it, and then do the same with pointing it upward, then we are concerned that we require more range of motion and therefore seeking or hoping that the doctor would be in agreement with us to perform a frenectomy. As a speech-language pathologist, when we are teaching sounds, and majority of the sounds in the English language all require the tongue to at least make contact with the alveolar ridge, which is the hard, bumpy structure behind your teeth, behind your upper front teeth, not directly behind, but a little bit further back. We need the tongue to be able to touch that spot on command so that overall articulation of, like I said, the majority of sounds in the English language can be produced and can be produced correctly. If a patient is unable to click their tongue or unable to make contact with their tongue blade or the middle of their tongue and their hard palate, then our concern is the patient's ability to control not only their chewed food, but to control their swallow. When a patient is chewing their food correctly and prior to swallowing, they make their food into a bolus or a ball. And that ball of food, whether it be something liquidy like applesauce or eating something tough or bulky like animal crackers or goldfish crackers, we need them to be able to not only create this ball or bolus, but we need for the middle of the tongue to help contain that bolus between the top of the tongue and the hard palate on the top of the mouth. That contact is what is supposed to allow for a controlled swallow without food falling off the tongue or remnants or residue stuck in the cheeks or in your teeth. In addition, all swallows originate at the spot, or at that point directly a little bit behind your upper central incisors or your front teeth, right on that alveolar ridge where all of those sounds are also made. That contact is also where the proper swallow originates from. So if a patient is unable to touch that spot on command without mobilizing their jaw, their lips, or their head, and just their tongue, or they are unable to make contact between the middle of their tongue and the hard palate, then the patient will most likely need myofunctional therapy in order to work on that overall chewing and swallowing and containment, but not before a frenectomy is completed, so that the patient has the ability to work towards that range of motion and work towards reestablishing how they're producing the sounds in the correct way, or how they're swallowing, but now in a correct way.